Welcome to all doctors, and I, on behalf of MK Pharmaceuticals, Dr. Ketan Kulkarni, welcome you all for this webinar on recent updates and clinical insights on hepatitis B management. And the purpose is basically today is the World Hepatitis Day, and it is celebrated all across the world. So with this thing we are doing this webinar today, and our speaker is Dr. Laxman Jessani sir. So I welcome you sir for this webinar. uh, Tushar, go to the next slide. Yeah, so I will just introduce sir. So Dr. Jesani is a consultant infectious disease specialist at Apollo Hospital in Mumbai, and sir has received numerous degrees in infectious diseases, FMB in infectious diseases, and also he's a fellow of Royal Society of Public Health in UK. And sir is recognized expert in the diagnosis and management of complex infectious diseases, and he has extensive experience in managing viral hepatitis B, HIV, tropical infections, and antimicrobial stewardship. Sir is the active member and faculty at the various national and regional CME programs, and he has contributed to physician education through various scientific lectures, case-based discussions, and evidence-based clinical updates. And his area of interest includes chronic hepatitis B, HIV medicine, viral hepatitis, tropical infections, and also antimicrobial stewardship. Uh, and for the audience, so we have a great opportunity to listen from Dr. Jesani sir and also get his valuable insights and advice today. So if you have any questions, please post in the Q&A link, which is there in this Teams link. And now I cordially invite Dr. Jesani sir to start the proceedings. Thank you, sir.
Thank you, Dr. Ketan Kulkarni, and thank you, MQR, for the very kind introduction and inviting me to be the speaker for this particular talk. So today we are going to discuss about the recent updates in hepatitis B management. Hepatitis B is very common in India. One out of three people can have hepatitis B if they have not tested it earlier, and the treatment management also needs to be seen how can we progress it. So without any further ado, I'll just share my screen for the presentation. Yeah, okay. So friends, we are going to discuss about the recent updates and clinical insights on the hepatitis B management. So friends, we all are aware about the hepatitis B. What is hepatitis B? So hepatitis basically means an inflammation of the liver. That is, the inflammation of the liver is called as hepatitis, and it can be caused by a virus infection. And there are usually five to six types of major viruses which can cause this hepatitis, which is called as viral hepatitis. And typically the viruses are as by hepatitis A, hepatitis B, hepatitis C, hepatitis D, and hepatitis E. Out of these five types of viruses, the hepatitis A and hepatitis E are basically the blood-borne virus. They are the fecal oral route hepatitis, that is, which is spread through water. That is spread through food and water, which is hepatitis A and hepatitis E. Whereas hepatitis B, C, and D, these are the blood-borne hepatitis, which means these are transmitted either through blood or through sexual contact or from mother to child. So what we are going to focus here is predominantly hepatitis B, which is the blood-borne viruses. So if you look at a comparison of all the five viruses, you can see the viruses, they have been identified in different period of time, and this is the size. Typically the size of a hepatitis B virus is 42 nanometers, and some of them are RNA viruses. Typically the hepatitis A, C, D, and E are the RNA viruses, but hepatitis B is a DNA virus which can either be single stranded or double stranded. It has an envelope around it, which is a double shelled envelope around it. That is why it is not very easy to kill the hepatitis B virus. And how it is spread, as I told you earlier, hepatitis A and hepatitis E, these are virus are waterborne, that is, it is spread through fecal-oral route. So if a person has hepatitis A or hepatitis E, he'll be shedding those viruses basically in his stools, and if those stools come in contact with water or if they are transmitted through food, another person will get infected. But when we talk about hepatitis B, C, or D, typically they are bloodborne, so they are usually parenteral. They are spread through either through direct blood contact, through sexual mode, or from mother to child infection. Not only that, the incubation period is also varies from virus to virus. Especially if you look into the hepatitis B virus, the incubation period can be anywhere between 1 month to 6 months. And if you look into the antigens, you have to look into the various antigens which are present on the hepatitis B virus, which includes the surface antigen, the core antigen, and the envelope E antigen. Out of this, the surface antigen is the one which we use typically for testing. So for screening a lot of people of hepatitis, typically we use the surface antigen, which is called as HBsAg. There is other antigen for the core and as well as for the envelopes. Not only the antigen, there are various antibodies which are formed against these particular antigens. For example, if you talk about hepatitis A or E, we are talking about predominantly antibodies against hepatitis A and E. But when we talk about hepatitis B, we have three types of antibodies. One is the antibody which is formed against the surface antigen, which is called as anti-HBs antigen. Now, this antigen is a marker for immunity. So, if you are infected with hepatitis B, your HBsAg will come positive. But if you are vaccinated against the hepatitis B, like for example, all of us are vaccinated against hepatitis B, then our anti-HBs antibody would come positive, which would give us protection against getting the hepatitis B infection. So anti-HBs antibody is a surface antibody which gives you protection from the hepatitis B virus. Then there is the anti-HBc against the core antigen, and there is the anti-HBe which is against the envelope antigen. The severity of infection, well, for hepatitis A and E, the infections are usually mild, except for probably in pregnancy. If you get hepatitis E, sometime it can have a very fulminant course. Hepatitis B infection has various stages of infection, that which we'll be discussing later on in a presentation. But hepatitis B can be mild, but it can be very severe as well. Chronic hepatitis is only seen with hepatitis B, C, and D. Otherwise, it is not seen in hepatitis A and E. So, hepatitis A and E are usually acute hepatitis in which your liver enzymes increases and it causes a hepatitis, and gradually it subsides. It does not go on to form of a chronic disease. But hepatitis B, hepatitis C, and hepatitis D, they go on to form a chronic disease like chronic hepatitis. Carrier state, many persons with hepatitis B can have a carrier state where they are just positive with the surface antigen, but it never causes the infection, nor never causes any disease in them. So what typically we call is the rule of 30. So what is this rule of 30? Is that out of 100% people who are infected with hepatitis B, 30% of the people will continue to remain positive. That is, the HBsAg will remain positive lifelong and it won't cause any problem to them at all. So they are called as the chronic carriers of hepatitis B. The second 30% of the population, those people, the hepatitis B may automatically become negative. That is, the virus may automatically shed and it may become negative. But it is the last 30% of the population in which the hepatitis B actually goes and infects the liver. And then when it infects the liver, it causes severe hepatitis. It can go into decompensated liver disease. It can go into liver failure, and the patient may actually need transplant. So it is only the 30% of the hepatitis B cases where we are actually worried, and these are the cases in which it can be severe or it can become a fulminant infection. Not only that, many times this hepatitis B, which remains as a carrier, can go on to develop hepatocellular carcinoma. So in this 30% of the population, we have to be very cautious and we need to screen them at regular intervals to see whether they are going into hepatocellular carcinoma or not. And prognosis, as I told you, as with hepatitis A and E, the prognosis is usually good, but with hepatitis B, as the age increases, the prognosis goes worse and worse. So this is just a brief overview about the different types of hepatitis, and our major focus would be basically on hepatitis B. So this is just a quick summary. How does the spectrum of hepatitis infection occurs? So if you look into any hepatitis, in A, B, C, D, or E, they have usually these four phases. So the first phase is an incubation phase in which basically the infection goes into your body, but it does not manifest so far. So that incubation period varies. As I told you earlier, it can be just 4 weeks for hepatitis A, it can be 2 to 8 weeks for hepatitis E, and for typically for hepatitis B, it can be anywhere between 1 month to 6 months. On an average, we can say around 10 weeks. After the incubation period where the hepatitis virus gets into your body and it starts multiplying, then it shows an initial pre-icteric phase, or also called as a prodromal phase. In this phase, what happens is basically the patient starts developing some symptoms, but still the jaundice has still not occurred. So in this phase, patients typically have anorexia, nausea, vomiting, fatigue, some mild headache, arthralgia. Many cases have fever as well, but it does not present with jaundice. So the earliest laboratory evidence of hepatocellular injury in this pre-ecteric phase is the elevation of transaminitis. So in this case, if you look into the LFT report, you will see the bilirubin is normal, but the SGOT-PT have started to elevate, and the patient has mild symptoms as well. The next phase comes is basically the icteric phase, in which the patient now develops jaundice and his symptoms actually diminish. So what anorexia, nausea, vomiting the patient would have, it will subside, and now the patient comes with jaundice. The patient will tell that he is having dark colored urine because of the bilirubinemia. He is having clay colored stools because of the cholestasis, and because of the bile acids which are present, the patient will have a lot of pruritus and itching, and patient will start to lose weight, and he'll have some abdominal discomfort because the liver now becomes enlarged and it will be tender. After the icteric phase is over, because the icteric phase lasts anywhere between 1 to 4 weeks, and then starts the post-icteric phase. And post-icteric phase is the one in which we can see whether the patient will either improve or the patient will either deteriorate. So usually in basically in hepatitis A and E patient's liver enzymes begin to subside, his bilirubin begins to subside, and the patient begins to improve. Recovery phase is usually more prolonged in hepatitis B and hepatitis C, but this phase, post-icteric phase, can be very dangerous because 1% of the cases of acute hepatitis may go into a severe form of disease, what we call as the fulminant hepatitis, in which the patient goes into acute liver failure, decompensated liver disease, then patient goes into severe hepatic encephalopathy, hepatic shock, and severe and finally mortality as well. 5 to 10% of the cases go on to develop chronic hepatitis. So hepatitis B infection many a times comes and it presents with jaundice, and then it subsides, and then just it becomes a chronic hepatitis, not causing any severe problem at all. So these are the various manifestations of our viruses. So number one is the carrier state. A carrier state is the one in which the patient is having the hepatitis B surface antigen positive, but it is not causing any problem, not causing any abnormalities. Asymptomatic infection is the one in which the patient's liver enzymes are elevated. Some of the liver abnormalities are seen. Hepatitis B viral load may be present, but patients do not have any symptoms. So we call it as an asymptomatic infection. Acute hepatitis is the one where the virus begins to multiply a lot and it causes an acute damage to your liver, in which your liver enzymes gets elevated, your bilirubin gets elevated, and everything occurs within a period of 2 to 6 weeks. So that is when it is called as a acute hepatitis. Chronic hepatitis is typically seen in hepatitis B and hepatitis C. It is not seen in hepatitis A or hepatitis E. Chronic hepatitis is the one in which the patient's liver enzymes are deranged. Hepatitis B viral load is present, but the patient is still relatively stable. He may have a slight amount of jaundice, but it does not causes any fulminant hepatitis. The next stage, which is the most dangerous stage, is basically the fulminant hepatitis, which may progress from directly from asymptomatic infection or acute hepatitis and goes into a fulminant hepatitis, in which there can be submassive to massive necrosis. Chronic hepatitis many a times goes on to progress into cirrhosis, and this cirrhosis may go on to produce into hepatocellular carcinoma. Now this again is typically seen in hepatitis B and hepatitis C. So these are the 6 manifestations in which these hepatotrophic viruses can be manifested. So let's focus on acute hepatitis. Now we are talking typically about the hepatitis B infection. So acute hepatitis is the most common consequence of all hepatotrophic viruses, and it is basically an acute inflammatory involvement of the entire liver. It is a sudden short-term liver inflammation, and typically it will resolve within a period of 6 months. Chronic hepatitis is basically defined as a continuing and relapsing hepatic disease which lasts for more than 6 months. So if you get a hepatitis infection and it subsides within 6 months, you had acute hepatitis and you have recovered. But if the symptoms persist for more than 6 months, then it is called as a chronic hepatitis. Let's focus mainly on our hepatitis B infection. So hepatitis B infection or the chronic hepatitis B, where the patient is positive with the surface antigen, which is the HBsAg, you can see it is present all throughout the world. Some areas, especially in Africa, you can see there is a dense involvement of hepatitis B. Many a times this hepatitis B is co-infected with HIV as well. India comes into the moderate list, in which basically you can say the HBS prevalence as in 2019 showed that the prevalence was anywhere between 2 to 4%. Now this virus, what does it do in your body? So our focus for the next remaining minutes of the talk would be on hepatitis B, because let us focus on hepatitis B and see what are the management guidelines for hepatitis B. So what happens is initially the hepatitis B enters into the body. So the enveloped hepatitis B, as you can see on your screen, attaches and enters the host hepatocyte, and partially the double-stranded genome is then released and transported to the nucleus. Later, what happens inside the nucleus, as you can see in the diagram, the viral DNA is converted into a closed circular DNA, which is a stable, long-lasting intermediate and the template for the viral RNA. Then there is a process of transcription in which the circular DNA is transcribed into the host polymerase 2, which is the RNA, and then it starts producing the viral pregenomic RNA and the messenger RNA. And once the messenger RNA is formed, then next step comes is basically the protein synthesis. So what happens is then some of the messenger RNA is translated into the cytoplasm to produce virus core proteins and the polymerase. Next step is basically called as encapsidation and reverse transcription. In this, what happens is basically there is the nucleocapsids which are formed, and inside the capsid there will be viral polymerase preforms which go into the reverse transcription, and then this is basically processes in which there is the new hepatitis B viruses are formed. And finally, after the reverse transcription, there is assembly and release, where the new synthesized circular DNA containing the nucleocapsids can either be released as a progeny virus, or they return back to the nucleus to replenish as the circular DNA pool. So either they form new virus or they go into the pool and starts multiplying again and forming more virons. So this is how a hepatitis B enters the hepatocytes, and other hepatocytes and other hepatitis B viruses are then produced. Transmission, as I told you, when we talk about hepatitis B, the transmission is mainly by 3 modes. One is from the mother to child. So if the mother is hepatitis B positive, if she has active virus replicating in her body, and if she is not treated during the time of pregnancy, she will transfer this infection to the baby. Second is by unsafe injections and transfusions. Nowadays, the blood and everything is screened for hepatitis B in detail. So there is very minimum chance of transfusion through blood. But if you are, it's there in a remote setting, there are no proper safe practices, then transfusion and through injections, hepatitis B can be transmitted. And finally is through the sexual activity. Now amongst the sexual activity, homosexuals who are involved in anal sexual activity, there is higher chance of hepatitis B transmission, and even among the heterosexuals through sexual activity, hepatitis B is easily transmitted. What are the risk factors? The risk factors, as I told you, it is a blood-borne viruses. So everything, the risk factors has to do with blood. So if you have frequent exposure to blood or blood products or other bodily fluids, you need to be careful because you can get hepatitis B. For example, if you are a lab personnel dealing with blood and blood products, as healthcare workers like us, like doctors, we are also at risk. That is the reason why it is very essential that all the healthcare workers get immunized with hepatitis B vaccine so that there is no chance of hepatitis B occurring. Hemodialysis again is a very common route in which the hepatitis B can be transmitted. That is why it is very important in all your CKD patients. You should tell them to get vaccinated with hepatitis B. Then men having sex with men, especially to the anal route, this hepatitis B is transmitted. IV or injection use, close contact with carrier hepatitis B. So we typically see many families in which one person is hepatitis B positive. It quickly spreads and other members of the family also become hepatitis B positive. So that is the reason why we advise that any person who is hepatitis B positive, all the other family members should immediately get vaccinated with hepatitis B so that there is no close contact, like there is an accidental blood exposure or something like that. As compared to HIV, blood exposure blood exposure with hepatitis B is much more common and it is much more transmittable. HIV virus dies immediately when it is outside the human body. But when it comes about hepatitis B, the virus can stay alive even outside the human body. So there are higher chances of contracting hepatitis B rather than HIV in these particular cases. And finally, there are some residential area with insanitary conditions in which basically hepatitis B can be transmitted. Now, this is a typical and a most important graph which you have to understand that how does the hepatitis B manifest and how does the various markers of hepatitis B occur. So if you look into on your y-axis, you can see the timeline which is weeks after exposure, and if you look into x-axis, you can see what is the level. So initial period, which is basically for hepatitis B, which is anywhere between 1 to 6 months, you can see basically there will be an incubation period where nothing will come positive. After the incubation period, your surface antigen begins to come positive, your envelope antigen begins to come positive, and the virus tries to multiply. So if you have to detect any person who is having hepatitis B at the earliest, you need to do their HBV DNA because this is one of the earliest to rise, followed by hepatitis B surface antigen and envelope antigen. After these markers, after say around 4 to 6 weeks, your antibody against the core antibody antigen starts rising, which will be anywhere between 4 weeks. So 3 weeks, this begins to rise, which goes up to 6 weeks. Next is the antibody, which begins to rise at the level of 4 weeks, and that is the antibody to your core antigen, that is anti-HBC. Followed by that, another antibody which is against your envelope antigen. This begins to rise at 6 weeks. Then after your IgM, the IgG antibody to your core antibody begins to rise at 12 weeks, and at 20 weeks the antibody against the surface antigen begins to rise. So if you have developed a surface antigen antibody which is positive and the other markers are negative, that shows that basically you had developed hepatitis B in the past, but this is the one which is last to rise. One of the manifestation of hepatitis B is the chronic hepatitis. So what is this chronic hepatitis B? It is a persistent inflammatory liver disease which is caused by hepatitis B infection. In fact, WHO estimates that almost 254 million people were living with chronic hepatitis B in 2002, and there was a lot of 1.1 million deaths primarily due to cirrhosis. Chronic hepatitis B is also the leading cause of primary liver carcinoma, that is hepatocellular carcinoma, and they expect that the numbers are only going to double by the year 2040. So this chronic hepatitis, it can remain in a healthy, this is a healthy liver. This is the one in which there will be chronic hepatitis which leads to inflammation, which leads to swelling of the liver. So the size of the liver increases and tenderness increases. After which the liver goes into a stage of fibrosis, in which basically then the liver starts developing into a cirrhosis. So after the next step of fibrosis, this is a cirrhotic liver where there is severe scarring and the liver function deteriorates, and finally the liver cirrhosis may go on to develop as a liver cancer. 20 to 30% of all adults with chronic hepatitis B will develop complications of cirrhosis or basically liver carcinoma. So you have to be cautious about hepatitis B. The pathogenesis, this we have already discussed. The hepatocytes are damaged. There is virus multiplication of the hepatocytes. Typically, the virus infects the CD8 cytotoxic cells. Then, basically, various immunological markers indicative of the presence of HBV infection are typically seen. After the incubation period, once the patient develops symptoms of hepatitis B, what are the symptoms that the patient develops? Typically, patient may just present to you with tiredness or easy fatigue. They may have low grade fever. They may have non-specific symptoms like joint pain, stomach pains, nausea, vomiting. And finally, when they go into the icteric phase, they present to you with jaundice. So there will be yellowing of the eyes or the skin, and there will be light colored stools or the dark urine which would be present. So what is the course of hepatitis B or hepatitis C? As you can see, these are the various manifestations. So acute hepatitis B or hepatitis C infection can form into a healthy carrier where the person will have positivity. HBsAg would be positive, but it won't cause any particular problem. The most common variety is the subclinical disease where basically the hepatitis B begins to multiply, but it gets healed on its own and the patients get recovered. The one of the more common varieties is the acute hepatitis B infection, wherein the virus multiplies, the liver's enzymes get elevated and destroyed, and they go on to form fulminant hepatitis, which is associated with mortality. And as I mentioned earlier, 20 to 30% of hepatitis B will go on to form chronic hepatitis, which will go on to form cirrhosis and which will go on to form hepatocellular carcinoma. So once when we have understood what is hepatitis B, how it is transmitted, what are the various manifestations and what is the prognosis, let us quickly go through what is the general management of hepatitis B infection. Typically, hepatitis B infection, as you said, it's a virus, so bed rest may be recommended. We have to only determine when to give the antivirals, which we will discuss subsequently. Adequate nutrition needs to be mentioned. Avoid other agents which can cause liver damage, for example, alcohol or the drugs. Increase the calories, increase the carbohydrates, and decrease the fat. So convalescence may be prolonged with complete symptomatic recovery, which may be requiring around 3 to 4 months. And during this stage, gradual resumption of physical activity is encouraged after jaundice is resolved. So if you are developed a mild acute hepatitis, you will recover basically in 6 months, and the jaundice will subside. If you still have persistent symptoms, then you will go on to form a chronic hepatitis B, which will last for more than 6 months. So what are our guidelines? So our guidelines are as recent as 2025, the AASLD IDSA practice guideline on the treatment of the chronic hepatitis B, and I'll show you some important guideline features which we need to follow. So for that, we have to understand what are the various terminologies of hepatitis B. So you have to understand when a patient comes to you with chronic hepatitis B, he can be in any of these 5 stages. First stage is basically an immune tolerant chronic hepatitis B, in which his envelope antigen would be positive, his hepatitis B DNA would be very high, it would be more than 1 crore, but his ALT and AST, that is SGOT PT, would be normal. The second type is the immune active chronic hepatitis B, in which again the envelope antigen would be positive. Here the DNA would be positive for more than 20,000 international units, but the ALT would be more than 2 times the upper limit normal. There is another variety of immune active, which is basically hepatitis E, that is the envelope antigen negative, but still the liver enzyme would be more than 2 times the upper limit of normal, and the hepatitis B DNA would be more than 2000. The third variety is inactive chronic hepatitis B, in which the hepatitis B, that is the envelope antigen, would be negative, and the hepatitis B DNA multiplication would be less than 2000, and it would be a normal liver enzyme. So when we talked about the first two types, the immune tolerant and the immune active chronic hepatitis B, they are the ones in which we need to decide whether to give antivirals or not. In inactive chronic hepatitis B, where the virus multiplication is not very high, the surface and the envelope antigen is negative, liver enzymes are normal, we can wait and watch, need not start on the antivirals for hepatitis B. Next is the indeterminate, in which again the envelope antigen can be positive or negative, with the hepatitis B DNA level being normal, and these are the ones who do not fit into the either of the immune tolerant or immune active. So this is what we call as a gray zone. Here we have to again take a decision whether the patient needs hepatitis B antiviral treatment or not. And finally, the HBS antigen loss is basically when the antigen becomes loss on antiviral therapy, or as I told you, 30% of the people automatically become spontaneously negative. Okay, so those patients who are previously HBsAg positive, they do not develop any symptoms. Just randomly over a few months or 2 years time, they become HBsAg negative. Again, in these patients, they do not require treatment. Another key terminology you have to understand is what is functional cure and partial cure. Functional cure is when we say that the surface antigen becomes negative and the hepatitis B becomes undetectable for at least 6 months. When you have this state, when you have achieved, that is the time when we say you have functionally cured with your hepatitis B infection. Partial cure is when we say that the surface antigen titers have decreased to less than 100 and the hepatitis B DNA is also undetectable for 6 months. So our aim is basically to go for functional cure, but many cases we only achieve partial cure with your antiviral treatment. So this is a very good management algorithm for patients without cirrhosis. So you have to differentiate the patients with cirrhosis and without cirrhosis. So this is basically the hepatitis B without cirrhosis who are surface antigen positive and who are envelope antigen positive as well. So how do we divide it? So you look at the patient's surface antigen, you see whether the patient is having cirrhosis or not cirrhosis. If the patient's surface antigen is positive, but the patient does not have cirrhosis, next step is you look into their envelope antigen. And if their envelope antigen is also positive, then four combinations are positive. If their DNA is more than 1 crore and their liver enzymes is less than upper limit of normal, they are basically the immune tolerant phase. In these patients, you just need to monitor their liver enzymes and their HBV DNA every 3 to 6 months. If they are age more than 40 years and on fibroscan they have F2 fibrosis, then we consider antiviral treatment. If they are less than 40 years, then we can just consider whether we need to give the antiviral treatment or not. Another situation is again when your hepatitis B DNA is there more than 1 crore copies, but your liver enzymes are up to is elevated but less than 2 times upper limit of normal. In these patients, again, basically you do a fibroscan and see if the fibroscan is more than F2 fibrosis, then we can consider treatment. Third situation is when the hepatitis B DNA is more than 20,000 but less than 1 crore, but the liver enzymes are also less. Again, now this is a gray zone. This is an interdeterminate zone in which we have to take a decision case by case basis. Again, if you do the fibroscan and if there is F2 fibrosis, you may consider antiviral treatment. But the one stage in which you definitely have to treat is basically the immune active phase, in which the person is surface antigen is positive, envelope antigen is positive, HBV DNA is more than 20,000 copies, and the liver enzymes are more than 2 times normal. This is the category in which you have to treat the patient with antiviral. So remember, this immune active phase you have to treat the patient. The other phases you have to look into the fibroscan, clinical condition, and then take on a case by case basis and then treat the particular patient. The second, so this was a possibility when we talked about when it was envelope antigen positive. Now let us talk about other case again without cirrhosis but envelope antigen is negative. Again, the whole idea behind that is to see which of these phase belong to immune active phase. So again, if your virus is less than 2000 and the ALT that is the liver enzymes is normal, you can just wait, no need to start the treatment. Again, if the liver enzymes is elevated but your HBV DNA is less, again you can just keep a close follow up, no need to start the treatment. But again, there is a gray zone where your hepatitis B viral load has increased, but your liver enzymes are still less than 2 times normal. This is the thing, again, you have to look into case by case basis, because many reports suggest that in these cases, if you don't treat, there are chance of the patient going into hepatocellular carcinoma. So again, you need to do on a case by case basis. But if you have envelope antigen negative, surface antigen positive, but the DNA is more than 2000 and the liver enzymes is more than 2 times the upper limit of normal, that is the immune active phase, you have to treat basically with the antivirals. So whole idea is to look whether the patient is having cirrhosis or not cirrhosis, patient's envelope antigen is positive or not, patient's viral DNA is more than 2000, more than 20,000, or more than 1 crore, and then take a decision on the treatment. So to summarize, this is just a very good algorithm in which you can actually go in a step-by-step process and see whether the patient needs any treatment or not. But as I mentioned earlier, typically the treatment, the antiviral treatment which is needed is basically present, especially if you are having a viral load which is very high. There is another condition in which we have to consider antiviral irrespective whether your hepatitis B DNA is elevated or not, and that is pregnancy. So many a times in pregnancy, if the pure hepatitis B positive, your HBV envelope antigen is positive, your HBV DNA is even more than 2000 only. In these cases, we prefer to start the treatment. The treatment includes either a TAF or TDF, that is tenofovir alafenamide or tenofovir disoproxil, which needs to be started at week 28, especially if the viral load of the mother is more than 2 lakh. And of course, vaccinate the infant and administer immunoglobulin immediately when the child is born. So that was basically when we talked about hepatitis B positive, envelope antigen positive or negative in a patient without cirrhosis. When I say without cirrhosis means there is no evidence of fibrosis on fibroscan. Clinically also the patient does not have any cirrhosis. The second set is basically a patient who is hepatitis B positive, but they have already gone on to develop cirrhosis, either compensated disease or decompensated disease. So that we have to see. So in these patients, if they already have developed cirrhosis, don't chase the hepatitis B viral load, because at any level of hepatitis B viral load, you have to start the treatment. The only question is to start on which treatment. So look at their condition. If they have compensated liver disease, that is they are not having any severe decompensation, treat them with either entecavir, tenofovir disoproxil, tenofovir alafenamide till the time their surface antigen becomes negative, and keep them in close follow up. But if they are having again a decompensated disease where they will have features of acute liver failure, for example ascites, hepatic encephalopathy, hepatorenal syndrome, in these cases again you have to start the treatment, but here you have to continue the treatment and don't stop the treatment. In compensated, you could stop the treatment once the surface antigen is negative. In decompensated, you do not stop treatment. You continue with the treatment lifelong. And in these cases, you should consider, in these patients, you should consider the liver transplantation, or if the liver transplantation is not possible, you should monitor for the surveillance system, that is the hepatocellular carcinoma surveillance. So what type of medicines which you should take? The preferred first line of medicines, especially in adults, adolescents, and even children between 2 to 10 years, is basically a tenofovir or entecavir. Previously, entecavir was the only medicine available, but now tenofovir is available. Entecavir is usually more expensive, so our typical first line would be used tenofovir. Tenofovir comes in two forms. It comes in tenofovir disoproxil fumarate, which is called as the TDF, and the second is the tenofovir alafenamide. So if you ask me which is the better tenofovir, the better tenofovir is the tenofovir alafenamide, especially for people who have established osteoporosis or who are having impaired kidney function, because tenofovir disoproxil can cause kidney function derangement, and it can cause osteoporosis as well. So this is basically your first line treatment. In cases where the first line treatment fails, or basically in spite of starting tenofovir, where the patients do not improve or they are not getting virologically suppressed, you may need to add a second agent. The second agent will be either a lamivudine or basically a emtricitabine. So typically we start with one agent, either entecavir or TAF or TDF. If they are not improving, viral is not getting suppressed, we can send the hepatitis B drug resistant testing, and then we may need to add a second agent like lamivudine in these particular cases. So with that, I have given you a brief overview about hepatitis B, how it is occurs, what are the risk factors, what are the mode of transmission, How do we classify the hepatitis B into various categories? What are their clinical presentations? How do we work up and send the various markers at various intervals in their disease? And then after diagnosing it, we identify the chronic hepatitis B patients, and then we see how do we manage. For that, we distinguish between patients who are having cirrhosis and no cirrhosis. Those who do not have cirrhosis, we look into their envelope antigen and the HBV DNA. And if they are in the immune active phase, we start them on treatment. If they are not in the immune active phase, they are immunotolerant phase, then we call them on follow up and see how they are doing. And if they are developing fibrosis, we start them on treatment. Whereas when we talk about cirrhotic patients with surface antigen positive, we look into whether they are compensated or decompensated. If they are decompensated, you start the treatment, which has to be taken lifelong. If they are in a compensated phase, you start the treatment, but you can stop it once the surface antigen is lost. So this was just a brief overview. And with regards to the medicines, I told you entecavir, tenofovir alafenamide, and tenofovir disoproxil. These are the three agents which are available, and they yield very good results. So with that, I'd like to conclude my presentation. If there are any questions, I'll be happy to answer. Thank you very much.
Thank you, sir, for your excellent webinar today. Uh, and you have brought a lot of clinical pearls in your presentation. So we'll take few questions. So this question is asked by Dr. Anuj. You can see in the chat this in Q&A box that do you foresee quantitative HBsAg or HBcrAg or HBV becoming part of routine clinical practice for individualized treatment decisions, especially in predicting the functional cure or relapse after treatment cessation?
Yes. So many a times we do quantitative surface antigen, especially when we have to see whether the patient is going into losing the surface antigen or not. So we do the surface quantity quantification. Along with that, we always do the quantitative hepatitis B DNA PCR. The RNA PCR is not done usually. It is usually reserved for if you want to detect in the infant which is born to a hepatitis B mother. We want to see that. But as a routine practice, we do the surface antigen. For determining if you want to stop the treatment, we do the quantitative surface antigen, we do the envelope antigen, we do the HBV DNA PCR, and we do a fibroscan. So these are the usual workup that we do in any patient when we are treating with the hepatitis B.
Right, sir. Another question is coming from Dr. Manjunath Dinakar. That is there a role of combined treatment with TAF and entecavir, especially in patients with high viral load?
Yeah, so I would not combine entecavir with TAF. I'd rather use the other mechanism of action. So typically what we use is TAF plus either lamivudine or emtricitabine with slightly different mechanism of action rather than adding TAF plus entecavir in this particular case.
Uh, right, sir. Right, sir. The few questions are there. Sir, which baseline tests are essential before deciding the management?
Yeah.
Uh,
So any patient who comes to you with chronic hepatitis B, he will come to you with a HBsAg positive report. So if he comes to you with HBs positive report, the test which you need to send is HBe antigen, that is the envelope antigen. You need to send is LFTs because you need to know the ALT and AST, what is the function of the liver. Third, you need to send basically the HBV DNA quantitative PCR because you need to see the what is the how much is the viral replication. You need to do an ultrasound abdomen basically to look basically if they are developing any fibrosis, fatty liver, or any cirrhosis like that. And of course, you need to do the fibroscan. The fibroscan is a must because it determines whether the patient is having fibrosis and going into cirrhosis or not. So these are the important tests which you need to do in any patient who comes to you with surface antigen positive.
right. Uh, Thanks, sir. And this question is from Dr. Anjali. That for a pregnant woman, do we start with tenofovir at diagnosis or start at 28 weeks of gestation?
We usually start at 28 weeks of gestation, especially when the viral load is very high. But if you feel that the viral load is high and she is having altered LFTs, you can start the tenofovir much earlier as well. Tenofovir alafenamide is quite safe in pregnancy, so that is not an issue. for with regard to pregnancy. The only question you have to see is the patient developing any features of active hepatitis. So if you feel that the patient's LFT is deranged, HBV, DNA, PCR when you checked on follow-up is increasing, you can start the TAF at a much earlier rate as well. Otherwise, you can wait till 28 weeks and then you start with the TAF regimen.
Right, sir. Thanks for your advice. And uh, some one or two questions more, sir. When do you suggest the patient should do a fibro scan or sometimes a liver biopsy?
So liver biopsy is usually not needed unless and until when you are suspecting hepatocellular carcinoma. Fibroscan is a good way to detect fibrosis. Typically for your chronic hepatitis B patients, we typically ask for fibroscan every 6 months to 1 year. If cost and other things is an issue, then we ask usually for 1 year, or else we ask them every 6 months to do. So along with the routine follow up with HPV DNA, HBe antigen, LFT, ultrasound, we ask a fibroscan for any patient who comes for follow-up, regular follow-up.
Right, sir. One more question is that, sir, which patients with chronic hepatitis B should receive an antiviral therapy?
Yeah. So as I showed you earlier, the patients whom you classify under immune active hepatitis. So these immune active hepatitis are the patients whose surface antigen is positive, whose envelope antigen is positive, whose HBV DNA PCR is very high, and their liver enzymes are more than 2 times the upper limit of normal. Or if they are hepatitis B positive but envelope antigen negative, but still they are either in compensated or decompensated disease with cirrhosis. So I had shown you in the entire chart and different bars, I showed you which patients definitely need to be started treatment, which are the immune active hepatitis. The other patients which are immune tolerant hepatitis, it goes on a case to case basis where you see them on follow up and then take a decision based on clinically and looking at their liver enzymes whether it is increasing or not.
Chetan sir, you are on mute.
So I'll invite more questions from the audience if they are there. Please put in the Q&A. We'll just wait for 2 minutes, sir. If there are
Sure.
any more questions. Okay, we'll take another question, sir. Is a bone health uh, if the if is the bone health important for treatment selection of an antiviral agent?
Yes, yes. So as I told you, the treatment includes tenofovir, which can be either be tenofovir disoproxil, that is TDF, or it can be tenofovir alafenamide. So previously we used to give only tenofovir disoproxil. So in those cases, what we notice is the patient usually had developed osteopenia going into osteoporosis, and the creatinine also gradually was getting elevated. So then came this molecule tenofovir alafenamide, which actually had a good and a good safety profile against your bones, so your bones did not become osteoporotic. There was good mineral density which was found, and even your creatinine was not getting elevated. So if you look into the choice of antiviral which I have to start in a patient who is having osteoporosis, I would always go for uh, uh, I will always go for tenofovir alafenamide, that is TAF instead of TDF.
Right, sir. Now questions are coming. So this is from Dr. Manjunath. Any recommendation for post-exposure prophylaxis following needle
Yes.
stick injury? Yeah.
Yes. So once you are got a needle stick with a patient who is hepatitis B positive, the first thing is you have to see whether you are vaccinated or not. If you have taken 3 doses of hepatitis B vaccine and you have a documented titer of anti-HBs antibody which is more than 10, then you are protected lifelong. You don't need to take any booster, you don't need to take anything. So even if you get prick with a hepatitis B positive patient, you are safe, you don't need to be worried. The problem arises that if you have got prick and you have had taken an incomplete vaccination, that is, you have not taken a vaccination completely, or you have taken 3 doses but your titers are less than 10, in those cases we need to cover you. So in those cases we recommend to give you hepatitis B immunoglobulin, because you are not protected, and then restart with your hepatitis B series again as 0, 1 and 6. So if you are protected, no treatment needed. If you're not protected, you need to take immunoglobulin along with the vaccine again.
Thanks, sir. Thanks. This question now is from Dr. Tejas. For pre-operative evaluation, if a patient gets diagnosed with HBsAg reactive, that is positive, with viral load meeting criteria for treatment initiation, is there a specific recommendation for this set of patients?
So you, just because the viral load is elevated, we don't take a decision whether to start antiviral. We also look at their clinical status and their SGOT-PT level. If a patient has a very high viral load, liver enzymes are more than 2 times normal, envelope antigen is also positive, we'll start with the treatment. So just because the viral load is high, that is not a criteria alone to start the treatment. You have to take into account the SGOT-PT levels as well before starting treatment.
Thank you, sir. Thanks. The questions are coming now. So this is from Dr. Uma Maheshwari. This is which vaccine is superior amongst various brands? Also, she's asking.
So I would not be promoting any particular brand, but usually the commonest brands that we use are basically Engerix, Shanvac, Revac B. So these are the common vaccine we use. One very important thing is whichever brand you use, the dose is very important. Many a times they feel that all vaccines are dosed as 0.5 ml, which is not true. You have to take 1 ml of the vaccine. So you have to take 1 ml intramuscular over the deltoid. Please don't take it in the gluteal area because the absorption is poor, plus risk to the sciatic nerve. So one dose is equal to 1 ml, which you have to take it on day 0, 1 and 6, or a accelerated regime of 0, 1, 2 and 1 year, or a still accelerated regimen of 0, 7 and 21, especially if you are working up for a transplant patient. But the dose has to be 1 ml. In patients with hemodialysis or with patients whose titers are not getting improved, we may actually step up the dose to 2 ml as well.
Okay, thank you, sir. Now, again, this question is from Dr. Nikhil. In patients who achieve complete viral suppression on long term, tenofovir or entecavir, how do you group them for ongoing hepatocellular carcinoma surveillance?
Yes, so for those patients, you will have to do a regular ultrasound. You need to do a fibroscan, and maybe if the patient is developing features of weight loss or because the ultrasound is slightly doubtful, you may need to do a CT abdomen in these cases.
Yeah, thanks, sir. These are the questions now from Dr. Uma Maheshwari. So, which do you prefer, tenofovir or entecavir? And SVR is achieved with which agent? Means
Yeah.
based on your practice. Yeah.
Yes, so I'll tell you both molecules are very good. The molecule which I prefer is tenofovir alafenamide because it has less side effects and it has very good penetration and it is very cost effective as well. But there is no randomized trial to show you that any one particular molecule is better than other. You can go for entecavir if it is available and if the cost is not an issue. But as per my practice, I would go with TAF, which is a very good agent, no side effects, and achieves very good. It suppresses the viral load very well.
Right, sir. Now, Dr. Uma Maheshwari is asking DM and HBV. So, ma'am, DM
Sorry.
means diabetes. DM and HBV. DM.
Okay.
I'm just asking her, is it diabetes mellitus or something else?
DM HPV, I didn't understand, sir.
Yeah, yeah. So, okay, coming to a different question. From which age group is now vaccination recommended for hepatitis B? Well, you said
Hepatitis B vaccination you can start at the infant age as well. There is no contraindication. Hepatitis B is recommended even for pregnant patients as well. So it is not a particular below, and it's a killed vaccine. It's a recombinant vaccine. So there are no side effects as well with that. So you can start it at infancy at 1 years of age as well.
right, sir. Right, sir. Now, this is the Dr. Umesh Maheshwari has replied. It is diabetes and hepatitis B. So whether you have got if diabetes patients, do you have seen hepatitis B virus infection and so
Yes,
on?
yes, it is quite common. In fact, what happens is many of the diabetics use insulin pens at home. So what I have seen is many a times they don't change the needles. They use the same needle. Sometimes the needles are shared at home as well for either for the prick test for testing your HGT or for taking the insulin as well. So many a times hepatitis B is common in the families, especially who are diabetics. Yeah, and the second issue is if you are a hepatitis B positive patient and you are taking insulin because of diabetes, the important issue is how do you discard the needle as well? Because then if you discard the needle randomly and because the hepatitis B stays in the environment for a longer time, any housekeeping or your garbage person, they are also at risk for developing the hepatitis B. So that is why it is very important to dispose of the needles very well. So diabetic patients, hepatitis B is not uncommon. It can be common because of this needle sharing thing. You're on mute, Dr. Ketan.
So sorry, sir. So how do you predict drug resistance to antiviral agents, and what investigations you do for it?
Yeah, so any patient who is having persistently high viral load despite the adherence being normal, you have to always check for adherence because many of the times patient tell they're taking the medicines but they are not taking. That is why they are not virologically suppressed. So if their viral load continues to be high, let's say more than 2000 international units, in spite taking the regular medicines, that and their liver enzymes are also getting affected, we would suspect that whether they are having any drug resistance. So you can do the drug resistance panel, which is available with most of the tertiary care labs, and then you can decide on the combination of medicine which you need to give.
Okay, okay. Thank you, sir. So we take only two questions now, then we close. So if a patient's virus is completely suppressed on entecavir or tenofovir, can we safely stop monitoring them for liver cancer,
Yeah.
or
So
monitoring is continued? Yeah.
yeah, so for these patients who are suppressed for quite a few years, you can consider them stopping with the treatment and keep a close follow up whether their surface antigen becomes negative or not, and whether their liver enzymes are becoming elevated or not. But usually, what we see is basically these patients typically require the medicines lifelong because when you take these medicines, their viral load is suppressed. But we have had cases in which the patients were started on medicines, they were on prolonged follow-up, then we stopped the medicines and still they continued to live normally. They did not have elevation of the liver enzymes, the HBV DNA PCR did not increase. So in those cases we can actually consider stopping the treatment, but in most of the cases usually the treatment goes lifelong.
All right, sir. I will take this last question. So, will functional cure, that is HbSAg loss, become a realistic goal in everyday clinic within the next 3 to 5 years? Or it will be there only few subset of patients?
No, it would not be that common that the HbSAg becomes negative very soon. So I would not say that HbSAg becomes negative. You need to follow up closely, or you may need to just keep a regular checkup of that. But it is not that common that hepatitis B surface antigen becomes negative. But as I told you earlier, rule of 30. So there is data to show you that up to 30% of the patients can become negative. But this is not an absolute number.
Right, sir. Right, sir. So, sir, uh, thank you very much for answering all these replies. And I
Ketan sir,
think,
Ketan sir,
yes,
just last question from chat box question.
there are thank you messages. Is there a question?
There is a question. I'm sorry, just to clarify, you mentioned for pregnant women we could consider to start earlier or wait until 28 weeks, right? If before 28 week, does the same rule as non-pregnant patient apply?
So if the patient is pregnant and the patient's viral load is not very high, you can wait till 28 weeks and then start the treatment. Because after 28 weeks, the patient is going to deliver at any point of time. There is going to be exposure of the mother's blood with the child. So that is the reason why at least till 28 weeks, if the mother's viral load is not high, you can wait with the treatment. But after 28 weeks or later, you should start the mother on the antiviral treatment. If the mother's viral load is high even earlier, then you don't need to wait till 28 weeks. You can start the treatment much earlier as well.
Right, sir. Now, this is the final question. Uh, yeah, your view on total HB score and IgM score.
Sorry, your views on?
Total at this, they have not written the full form. Total hepatitis B core and IgM core, something like that.
Yeah. So if you look into the anti-HBC antigen, which is the core antibody against the virus, that is the time when we look whether the patient has any evidence of past hepatitis or not. So this is typically important for us in patients who are going for transplant. So as a routine workup, in fact, for any transplant, solid organ transplant, whether it is for liver, whether it is for heart or anything, we always do an anti-HBC total. Because if the anti-HBC total comes positive, that means the patient already had some amount of infection in the earlier, but because the HBsAg is negative, the patient does not have any active infection, or because the DNA PCR or the envelope antigen is negative, patient does not have any acute infection. But in these transplant patients, the core antibody is very important, because post transplant, when you give them immunosuppression, there can be reactivation of the hepatitis B disease. So that is the reason why we check this core antibody in transplant patients. Otherwise, for routine purposes for a hepatitis B treatment, we don't need to do this particular test.
Right, sir. Right, sir. Hmm. Dr. Uma Maheshwari, last question, sir. This after this, it will be we are closing. He is asking about occult hepatitis B infection. What are the challenges in detection?
So occult hepatitis B we do see occasionally, but the challenges are basically we need to monitor their viral load, because many a times their viral loads are not very high. So we sometimes are in dilemma whether these is true hepatitis B infection or whether it is just a cross reaction. So we need to monitor. So when in doubt about hepatitis B, always send for the hepatitis B viral load, because surface antigen may be negative but the viral load may be positive. So I would suggest rely on the viral load in these particular cases.
Right, sir. So many doctors, Dr. Maheshwari has thanked you. Many doctors have you have given your expert advice and they are thanking you. Uh, so finally, sir, we'll end with a vote of thanks. So I thank you very much for coming for this webinar and giving lot of clinical pearls and your practical advices to the doctors who have attended this webinar. So from MCure side, I wish you a great day ahead and thank you so much, sir. Thank you.
Thank you. Thank you.
Thank you.